Thank you, Uma, and the organizers for my assignment today. So, let's see if we can get this to advance. So there's a pretty good pipeline. Perhaps there's several drugs that I'm not going to talk about. Sorry, can we advance that once more, please? Once again, can we advance this? All right, maybe it's going to stay. All right, so what I would call these anti-integrin or selective adhesion molecules, the gut-selective molecules, both Steve and Bruce have talked fairly extensively about vedolizumab and where that fits in. There are three more drugs in this class, etrolizumab and AMG 181, which are both anti-beta-7 antibodies, and anti-MAdCAM antibody, which is the other side of that ligand relationship. So there is a little bit of phase 2 data with etrolizumab recently published in The Lancet, and with anti-MAdCAM published in Gut some years ago by Séverine Vermeer, showing that each of these other strategies looks like work in ulcerative colitis, and these are heading into phase 3 trials. Because Bruce and Steve talked about sort of this class of drugs, I'm not going to spend time really on the other drugs in that class, except to say that they'll be, I think, equally interesting and exciting as vedolizumab. So I want to talk about three classes of drugs that are either sort of in phase 3 or coming into phase 3. One is an S1P1 receptor modulator, then Janus kinase or JAK inhibitors, anti-P40 or anti-interleukin 12/23 drugs, and then there's a few other things that are in various early phases that we won't spend too much time on. So it'll be these main three classes. So we'll start with the JAK inhibitors. This is a list of various JAK inhibitors that are in development. There's various selectivity. Tofacitinib is a bit more of a pan-JAK inhibitor, so 1 and 3, but there's a bit of 2 as well with dose dependency. And structural rational drug design can sort of dial in or out relative selectivity of JAK1 or JAK3 or JAK2. JAK2 is more for hematologic diseases, potentially JAK1 for sort of immune suppression without too much side effects, and there's a number of drugs in development now looking at that. But the ones where we really have data are tofacitinib, so we'll spend a little time looking at that. So tofacitinib ends up having a fairly pleiotropic effect. It affects interleukin 2, 4, 7, 9, 15, and 21. Sounds a little bit like steroids or something. So it affects multiple cytokines. It's a real immunosuppressive, but it has real efficacy, as you will see. And so we'll look at phase 2 data in ulcerative colitis. These were data published a couple of years ago. The primary measure was response at week 8, and you can see about 40% on placebo. And then this nice dose response peaking out with the 10 and 15 milligrams BID dosing. And then if we look at remission, this is very nice remission data for both 10 and 15 milligrams BID, and not clear dose response between those two, but then clear dose response compared to the lower concentrations. And Steve just made the point that with biologic agents, there's huge inter-patient variability that's impacted by a variety of factors on drug clearance and pharmacokinetics. By contrast, if you look at a small molecule like this, for any given dose, the drug concentration between patients is very tight. So you have not only sort of linear dose response, but you have linear PK that's quite predictable between patients. So eventually, I think these small molecules would have some marked advantages over biologics for getting rid of this interpatient variation. Looking at mucosal healing, or what I would call endoscopic response, meaning that patients went from a Mayo Clinic endoscopy subscore of 2 or 3 down to 0 or 1. You can see this nice dose response again compared to placebo. And then going for complete endoscopic remission, so scores of 0, and I'm not showing that you also have that same dose response. So that's ulcerative colitis, really quite robust phase 2 induction data. What about Crohn's disease? So this looks a little bit more problematic, and if these data turn out to be real, this probably should be reverse engineered by the scientist to tell us, why would JAK inhibition work for ulcerative colitis and not for Crohn's disease? There must be a real pathogenesis story. A few caveats. This trial was only a 4-week trial. There was no extension option, and so you have to kind of think, what sort of patient would go into this? At the time that we were recruiting this, I was at Mayo, and I remember the patients that we put in were basically uninsured patients who had no other treatment options, not very representative of the broader patient population. It took a couple of years to recruit at multiple centers, a 120-patient trial. So I think it's not a very generalizable patient population. So that's one of the issues. And then if you, let's see, this didn't work out very well. So what these 2 slides are supposed to show is that there actually was a dose-dependent reduction in C-reactive protein and a dose-dependent reduction in fecal calprotectin. It was very clear at the highest dose that we studied, 15 milligrams BID, you had a marked biomarker response. So good, here we go. So you can see this reduction with the highest dose for CRP and also for fecal calprotectin. So how is it that we didn't have a clinical response at 4 weeks and you could see this biomarker reduction? Again, I think it sort of comes back to patient characteristics. So a much larger phase 2B trial where everybody who comes into the trial gets a baseline colonoscopy to ensure that they have active disease, and then it's a longer duration trial is running now, and it's a larger study. So I'm personally kind of in suspended animation about whether this will work in Crohn's or not. My hunch is that it probably will, but obviously we'll need data to see that. But what I would say is don't conclude that JAK inhibition is not going to work for Crohn's disease, because I think these biomarker data are actually really encouraging. What about side effects? So here's some of the stuff that we know about it from rheumatoid arthritis, where there's a much larger experience. So there are infections, including tuberculosis, so that's something to look about. There's been some association with lymphoma and other solid tumor malignancies. There's a rare possible risk of perforation, although I don't think we've really seen that as a big problem in the ongoing phase 3 program in ulcerative colitis. You can see a rise in both LDL but also HDL cholesterol in some of the patients, and the hypercholesterolemia is very responsive to statin therapy if that occurs. You can occasionally see liver enzyme elevations, and then you can see cytopenias that are reminiscent of what you see with azathioprine and 6-mercaptopurine, but at a somewhat lower frequency, and it's class or category C for pregnancy. So what I would say is the safety profile is fairly similar to what we're used to with azathioprine and 6-MP and maybe methotrexate and maybe the anti-TNFs. The efficacy in ulcerative colitis looks very good with remission rates, if those end up being reproduced in phase 3, and the 40 to 50% range. And I think this drug and this class of drugs will have a place in IBD in the future as I look in the crystal ball. So what about the second sort of future group of drugs? And the next one we'll talk about is anti-P40, and P40 is shared by interleukin 12 and 23. So when you target P40, you hit both of those cytokines. And ustekinumab is currently in clinical practice for psoriasis, so there's quite a big experience, clinical trials and clinical practice, and it's now in phase 3 for Crohn's disease. And it's approved, as I said, currently for psoriasis and psoriatic arthritis at a dose of 45 milligrams if you weigh less than 90 kilograms, and then 90 milligrams if you weigh 100 kilograms or more. It's dosed at 0 and 4 weeks, and then every 12 weeks for psoriasis and for psoriatic arthritis. So what about Crohn's disease, So these are some phase 2A data that we published a few years back, and what you can see in the upper left was there was a significant advantage for clinical response with the ustekinumab at various doses at weeks 4 and 6, but by week 8, the placebo rate had ticked up, and so the primary endpoint was not met. However, if you went back and did a subgroup analysis of the patients who had previously been treated with infliximab, then you could see this nice treatment effect throughout the 8-week dosing interval. So this led to a larger phase 2B trial with dose finding entirely focused on anti-TNF failure patients. And what you can see is that you can have about twice the rate of clinical response in these often even anti-TNF 2 or 3 failure patients compared to placebo. The remission rates over 6 to 8 weeks didn't achieve statistical significance, but these started out with very high degrees of illness. Many of the patients were in the CDI scores of high 300s or 400s, and realizing to get all the way to an absolute score of less than 150 is a long ways to come down over 6 to 8 weeks. So you can see a response early on, 100-point change from baseline, very clinically meaningful, but often not getting to remission during the induction period. However, if you take the patients who have that 100-point change from baseline and re-randomize them to drug or placebo and follow them, then you can see that you end up eventually getting remission rates amongst the responders during the maintenance period. So here you can see the maintenance of response rates and the maintenance of remission rates, which really look quite good in this incredibly difficult to treat patient population. And then here's steroid sparing. So even in a relatively small group of patients, about 150 patients, you can see a nice steroid sparing effect. So this is steroid-free clinical remission in anti-TNF failure patients with a very high baseline disease activity. So this is quite a tough outcome to achieve in a tough group of patients. What about side effects for ustekinumab? So we know, again, mostly this from another disease area, psoriasis and psoriatic arthritis. You can see serious infections, but relative to anti-TNF agents, I think the infection story has been less clear-cut here, and particularly there's not the opportunistic infection story with tuberculosis and antifungal or with fungal infections that you see with anti-TNFs. There have been some malignancies, but again, really not much different from the control population. So really quite a good safety profile in the psoriasis and psoriatic arthritis setting, and we'll learn a lot more about this in the large phase 3 program that's going on in Crohn's disease. There's also a thing, this kind of confuses patients and sometimes freaks them out. So there's this reversible posterior leukoencephalopathy syndrome, RPLS, and patients will come in and they think this is PML. Well, it's not PML. It's not a viral disorder, and you can recover from it. It's very unusual. I've not seen a case in the Crohn's clinical trials. But the big thing is that this neurologic syndrome is not an opportunistic infection. It's not PML, and it's quite rare. The last thing that I'll talk a little bit about is the sphingosine 1 phosphate receptor 1 modulation, or S1P1 modulation. So this is an agonist that ends up downregulating the receptors that allow lymphocytes to exit from lymph nodes. And so it's an agonist, but it's a functional antagonist, and it basically traps lymphocytes into lymph nodes, but it's not all lymphocytes. It's a subpopulation of lymphocytes. There's a drug called fingolimod that is currently approved for multiple sclerosis. About 100,000 patients or so have been treated with it worldwide. There doesn't seem to be a risk of PML with that drug compared to natalizumab, where there's clearly a risk of PML. So it appears to be a somewhat more selective immune modulator in the multiple sclerosis setting that's not been associated with an increased risk of opportunistic infection. So recently, a press release came out about an S1P receptor modulator in ulcerative colitis. This was a clinical trial in about 200 patients that looked at several doses of drug compared to placebo in moderate to severe ulcerative colitis. And there was a significant difference for the highest dose for remission rates and response rates. I expect that these data will be presented in full form at meetings over the course of the first 6 months of next year. So stay tuned to this. This is, I think, an interesting class of drugs that we're going to see much more of in the years to come. So I'll conclude there that agents targeting multiple targets, including the P40 subunit of IL-12 and 23, various Janus kinase combinations, and S1P receptor modulation, I think hold great promise for the intermediate term therapy for our patients. And of course, we have the full range of anti-androgens that are under development that will complement vedolizumab as well. So thank you.